Today, I'm going to discuss genomic evaluation of chronic lymphocytic leukemia and how our lab decided to transition from a SNP-array CGH platform to a NGS-based CNV plus SNV approach. First, I have no conflicts of interest to disclose. As you well know, CLL is the most frequent adult leukemia in our populations, with an annual incidence of 2 to 6 cases per 100,000 people. It can manifest in a ganglionic form, but most cases present as a leukemia characterized by a monoclonal lymphocytosis. Newly diagnosed or treatment-naive patients are classified using the CLL IPI, which combines both clinical and genetic characteristics of the disease. These characteristics define 4 risk levels with distinct overall and median survivals and will lead to the ultimate clinical decision to treat or not to treat the patient. As you could see in the previous slide, only the TP53 alterations, mainly gene deletion, has a specific value in the CLL IPI. On the other hand, in their recent clinical practice guidelines, NCCN gives more room for genetic factors and will propose therapeutic avenues according to the findings. If there is no treatment indication, then the clinician will wait and observe the patient. And when treatment indication is present, or a treatment failure or relapse, then the clinician will perform a complete genetic evaluation. Since more than 25 years now, FISH is the gold standard to perform genetic evaluation of CLL. 5 different types of results can be distinguished by targeting 4 chromosomal regions. Both deletion 17p and 11q are associated with unfavorable prognosis. In a survey of FISH results issued by our lab in 2015 and 16, 40% cases had normal FISH results, and the remaining 60%, representing 129 patients, had those anomalies. Even though some hematologists are reassured by a favorable result, targeting these 4 regions is costly, and many labs face budget restrictions. So the combination probe ATM-TP53 becomes appealing. At the end of the day, FISH still has its limits and is unable to detect complex karyotype or multiple clones with a few exceptions. With the advent of synthetic mitogens that replace pulquedes as a, we must say, poor B-cell mitogen, CLL karyotyping has gained new adepts. Complex karyotypes associated with an advanced disease and unfavorable prognosis can be observed, as well as multiple trisomies accompanying trisomy 12. However, it doesn't replace FISH, which means more labor into the lab. The quality of chromosomes obtained is not the best, and karyotyping remains difficult for CLL. In an effort to simplify the workflow into the lab and gain more insights into the genomic profile of CLL, array CGH can be used to replace FISH with a turnaround time similar to karyotype in our lab. We do have a small lab. The analysis is simple most of the time, and less hands-on time is required, since these onco arrays are labeled at the same time as our constitutional arrays. The ability to perform an whole genome analysis is a plus, as is visualization of genomic complexity. However, for a subset of clinicians, this can be viewed as too much unnecessary information when first treatment decisions come. This remains a costly analysis too, but in my opinion, not significantly more than a full FISH analysis or karyotyping. However, mutations are not evaluated and need to be done separately. Actually, our center performs a genomic evaluation of CLL using array CGH, and a sendout is made for IGHV mutational status. For most cases, either at diagnosis or at therapy failure, TP53 sequencing is not done. only occasionally TP53 is sent out for sequencing. Thus, we would like to give all our patients an easy, automatic access to TP53 sequencing. When we were presented an NGS test that would permit both gene sequencing and targeted CNV detection for CLL, we were a bit doubtful. On paper, it looked great and promising. Two of our current clinical concerns would be fulfilled: have easy access to TP53 sequencing, and give targeted CNV results for treatment-naive CLLs as per NCCN guidelines. However, would an NGS assay really be able to detect accurately large CNVs as observed in CLL? Then we were offered to participate in a product development trial, and we said, sure, yes, we're interested. So we sent out 32 DNA samples from patients already characterized by array CGH. All tissue and aberration types were present. Of course, I included some tricky samples to push the test at its limits. I must admit that when the results were presented to us, we were impressed. In the next slides, I'm going to show you some of these samples with side-to-side CNVs detected by array CGH and by NGS. To begin, an easy one, a classic trisomy 12, easily detected with both technologies. Then a complex case, number 18, with deletions 13q and 17p in all cells, and a mosaic deletion 11q. Here, a nice type 1 deletion 13q with a good detection by NGS centered around DELU1 and DELU7. And then the deletion 17p, which extends past the centromere on the array CGH profile. As you can see, the NGS coverture extends that far too. I'm really impressed. And finally, for case 18, the complex mosaic deletion 11q. With this one, I wanted to know how extended was the coverage along the 11q arm. By array CGH, the ATM-centered deletion spans 28.4 megabase versus 27.9 megabase for NGS. And the mosaic is well detected and estimated quite similarly, with an L frequency of 40% by CGH, which represents 20% of cells, and a tumor content estimated at 27% by NGS. I am happy with that. And now, the last case for today. Case 21, another tricky mosaic one. As you can see, mosaic deletion 13q is also well detected by NGS. I am very happy with this one, since I had manually flagged this deletion on the CGH profile. At the end of the day, this trial was very convincing and would trigger us to favor its clinical implementation. Last year, we gave priority to clinical validation of this approach. Of course, with COVID, things didn't went as fast as we expected. We decided to validate enzymatic DNA fragmentation, and I must admit, this wasn't easy. We introduced a DNA cleanup step on impure beads prior to fragmentation, and it made things more reproducible. Then we built our normal reference dataset using DNA from CLL patients with normal array CGH results. Finally, abnormal case validation could start this spring. Now, I'll show a few validation results obtained so far. We were happy to be able to detect nice 13q biallelic deletions, such as this one. Also, large 11q deletions were readily detected, even in this case with a smaller deletion on the second allele. Validation will be done using two bioinformatics protocols, the second one being designed to detect low mosaics. Up to now, using the classic pipeline, most abnormalities were detected by the software. As for the undetected ones, I'll need to pass them on the low mosaic pipeline to have the aberrations called. However, they are visible by looking at the CNV track. For the next weeks, I'll be sequencing cases with known low mosaic abnormalities, as well as defining my lower detection limit by downsampling the FASTQs for a subset of cases. I also have some intragenic ATM and TP53 deletions, for which BAM files will be reviewed. As part of our SNV validation, DNA from patients with Lee-Fromines syndrome and ATM-related breast cancer will be sequenced. And finally, we will be able to launch the test, hopefully by the end of summer, and propose a new testing algorithm to our clinicians. We will need more information from them in order to add a microarray to patients with relapsed or refractory disease. We think and hope that our clinicians will find it useful to have an easy access to TP53 sequencing data, as well as other relevant genes mentioned in the recent evidence-based review published by CGC. All but one gene mentioned as unfavorable prognosis in this paper are sequenced in OGT's SureSeq CLL CNV NGS panel. Finally, I would like to thank the organizers for this opportunity, and I will conclude my talk